Yahoo! Welcome back to the deep dive. I hope you are strapped in, caffeinated, and ready to roll today.
I am loving this energy right out of the gate.
Oh, we are absolutely bringing it today because we are jumping into the medical literature to decode what I am officially declaring the most underrated, most mysterious, and secretly the coolest superhero of the entire human body.
And honestly, I have to agree with you completely. I mean, we usually spend so much of our time obsessing over the heart, right? The pump.
Right, the heart, the brain, the computer.
Exactly. But today is all about the purple powerhouse.
Yeah, that's right. We are talking about the spleen. And look, I know what you're thinking listening to this. You're sitting there thinking, the spleen. Isn't that just that thing I can live without? Doesn't it just sit there?
A lot of people think that.
They do. But oh, my friends, you are so wrong. It is so much more than a disposable filter.
It really is.
We have a massive stack of sources today. We are talking deep embryology, high-stakes vascular surgery, rare genetic diseases, full-scale immune system warfare.
It's a fascinating journey. We are going to decode this organ from its very first days in the embryo, watching it fold and rotate. We'll look at its role as a master recycling plant, an immune headquarters, and a reservoir for your blood.
Yeah.
It's complex, it's elegant, and it's actually surprisingly fragile.
And the best part is that it's a survival story. I mean, we used to think this thing was totally dispensable. Doctors would just whip it out if it looked at them funny during surgery.
Toss it in the bucket.
Exactly. Oh, nick the spleen. Toss it out. But now we know that without it, you are walking around with a massive chink in your armor against some seriously nasty bacteria.
That's very true.
So let's stop wasting time. Let's unpack this purple organ.
Let's do it. To understand the spleen, to really get why it sits where it sits and does what it does, we have to start at the very beginning, the blueprint.
The origin story. I love embryology because it explains all the weird design choices in the adult body. So where does this thing actually come from?
It starts in the fetus. We are looking at the mesoderm. Specifically, we are looking at condensations of mesoderm in something called the dorsal mesogastrium.
Okay, let's unpack that immediately because dorsal mesogastrium sounds like a prehistoric dinosaur.
It does sound like a dinosaur.
Basically, we have the gut tube in the embryo, right? And it's hanging from the back wall.
Right, exactly. Imagine the primitive stomach. It's suspended from the back of the abdominal wall by a double layer of membrane. That's the dorsal mesogastrium.
Okay, got it.
Now imagine a little cluster of cells, a condensation, forming right inside that membrane. That little cluster is the future spleen.
So it's growing inside the sheet that holds the stomach. But the stomach doesn't just stay still, does it?
No, and this is the crucial part. As the embryo develops, the stomach rotates. It turns to the right.
Okay.
And because the spleen is tethered to it via that membrane, the spleen gets swung over to the left side of the body.
It's like a dancer spinning her partner. The stomach spins, and the spleen gets flung out to the left.
That's a great visual. And as this happens, that original membrane gets twisted and folded, creating two very distinct ligaments. These become the spleen's anchors.
Anchors.
Yes, one part connects the spleen to the stomach. That becomes the gastrosplenic ligament.
Okay, anchor number one is spleen to stomach.
And the other part connects the spleen to the posterior abdominal wall, specifically near the left kidney. That forms the lienorenal ligament. Lieno for spleen, renal for kidney.
So it's basically suspended like a hammock between the stomach and the kidney.
Precisely. It's like the spleen is building its own suspension bridges to its neighbors before it's even fully formed.
Wow.
And this matters because inside those bridges, those ligaments, run the vital blood vessels. If a surgeon cuts those ligaments without thinking, they aren't just cutting tissue, they're cutting the fuel lines.
I love that image. It's physically tethered to the stomach and the kidney, swinging in the breeze of the abdomen. Now let's talk stats. The tail of the tape. If I'm holding a spleen in my hand, which thankfully I'm not right now, what am I holding?
Well, in a normal adult, it weighs anywhere between 75 and 250 grams.
So roughly the weight of a large apple or maybe a heavy orange. It's not huge.
No, it's quite modest. And for dimensions, medical students have used a classic mnemonic for decades. 10 by 7 by 3 centimeters.
10 by 7 by 3. That's surprisingly compact. It sounds almost like a bar of soap. A large purple bar of soap. And where exactly is it hiding?
It's tucked away in the left hypochondrium, that's the upper left quadrant of your abdomen. It's sandwiched tightly between the gastric fundus, which is the top dome of the stomach, and the left hemidiaphragm.
It's like it's hiding in a little cave. The stomach is in front of it, the diaphragm is above it.
And it's well protected from the back, too. Its long axis runs right along the 10th rib. That rib acts like a physical shield.
Which brings us to the palpation puzzle. This is something I found fascinating in the source material. You can't actually feel a normal spleen, can you?
No, you absolutely shouldn't be able to. It sits too far back and is protected by that rib cage. If a doctor presses on your abdomen under your ribs and says, "Oh, I can feel your spleen," that is not a good sign. It usually means the organ has enlarged to about 3 times its normal size.
3 times? Wow. So it has to be massive before it even peeks out from under the ribs.
Exactly. It grows down and forward. And if it is huge, there's a key identifier on the anatomy that confirms it's the spleen and not, say, a kidney tumor.
What's that?
The spleen has a distinct notch on its inferolateral border.
A notch. Like a little bite taken out of it.
Yes, exactly like that. It's a remnant of that lobulated development back in the embryo. So if you're palpating a mass in that area and you feel a distinct, sharp notch on the edge, you know with high confidence, okay, that's the spleen.
It's like a little fingerprint. I'm the spleen, check my notch.
Mm-hmm.
Let's stop plumbing. Because the blood supply to this thing sounds absolutely wild in the literature. The notes describe the artery as tortuous.
It is remarkably complex. The main feed is the splenic artery, which comes off the coeliac axis. That's the main highway for the upper gut. But unlike the renal artery, which goes straight to the kidney in a straight line, the splenic artery is a serpentine mess. It winds and curls like a snake.
But why? I mean, nature usually loves efficiency, right?
Mm-hmm.
A straight line is the shortest distance. Why make the splenic artery a curly straw?
That is such a great question. Think about where the spleen is attached. It's attached to the stomach.
Yeah.
The stomach expands and contracts massively depending on whether you just eat a huge Thanksgiving dinner or you're fasting. The spleen has to move with it.
Oh, wow.
If the artery was a straight tightrope, it might snap or kink when the stomach expands. The tortuosity, the curls, give it slack. It's like the cord on an old landline telephone. It can stretch out.
That makes so much sense. It's built-in slack for the stomach's movement. But it runs right along the top of the pancreas, doesn't it?
It does. It runs along the upper border of the pancreas, giving off little branches to the pancreas as it goes. It's a very intimate relationship.
And that sounds like an incredibly dangerous neighborhood for a surgeon.
It is extremely dangerous.
Yeah.
The splenic artery and the pancreas are basically neighbors sharing a very tight fence.
Right.
If you're operating on the pancreas, say for cancer or pancreatitis, you have to be terrified of hitting that splenic artery. And conversely, if you're taking out the spleen, you have to be so careful not to damage the tail of the pancreas, which sits right in the splenic hilum.
It's the hilum. That's the entry and exit door for all the vessels, right?
Correct. The hilum is where the splenic artery splits into superior and inferior branches and where the splenic vein exits.
And the vein runs behind the pancreas.
Yes. The splenic vein runs behind the pancreas, picks up some tributaries, and then joins the superior mesenteric vein to form the portal vein.
Okay.
This is crucial. The spleen's drainage goes straight into the portal system, heading directly for the liver.
So the pressure in the spleen reflects the pressure in the portal system. That's going to be really important later when we talk about liver disease, isn't it?
It's incredibly important. If the liver is backed up, like in cirrhosis, the blood can't get in. It backs up down the portal vein, back down the splenic vein, and the spleen swells up like a balloon.
Okay, we've got the blueprint. We know where it is. We know how it's hooked up. Now I want to get inside. Let's open the doors and look at the inner machinery. Because the spleen isn't just a blob of purple tissue. It has a very specific internal structure.
It has a beautiful architecture. It's wrapped in a capsule made of collagen and smooth muscle.
Wait, smooth muscle? So it could actually contract?
To a degree, yes. In some animals, like dogs or horses, the spleen is a massive reservoir of blood.
Really?
Yeah. If a horse gets scared and needs to run, the spleen physically squeezes, dumping extra blood into the system for a boost of oxygen. Humans have lost a lot of that contractility, but the smooth muscle is still there in our capsule.
That is wild.
And that capsule sends down these beams, called trabeculae, penetrating deep into the organ to support the structure. It's like the steel girders of a building.
And inside that building, we have 2 main departments, the red pulp and the white pulp. This sounds like a Dr. Seuss book, but I know it's serious immunology.
It is very serious. This is the core concept to understand how the spleen works. The white pulp is the immune hub.
Like the Situation Room.
Exactly. Think of it as tiny islands of immune tissue floating in a sea of blood. It consists of lymphatic nodules with germinal centers and something called PAS, periarterial lymphatic sheaths.
PAS.
Yes, these sheaths wrap around the arterioles like a sleeve. They're just packed with T lymphocytes and macrophages.
So blood comes in, and the white pulp is just scanning it immediately.
Yeah.
Are you a virus? Are you a bacteria? Do you belong here?
Right, and there's a specific area called the marginal zone at the edge of the white pulp. This is border control.
Well, okay.
Plasma gets filtered here, and if there are any particles or antigens, the immune cells pounce on them. This is where the immune response against blood-borne pathogens begins.
And then we have the red pulp. This is the filter, right?
Yes. The red pulp makes up the vast majority of the organ. It consists of cords, called the cords of Billroth, and venous sinuses. And this is where the circulation challenge happens.
Oh, I love this part. I spent way too much time reading about this. This is literally an obstacle course for blood cells.
It really is. The spleen has a highly unique circulatory system. About 90% of the blood flow through the spleen goes through what we call open circulation.
Open circulation, meaning the blood isn't in a tube.
Exactly. The blood leaves the capillaries and is effectively dumped into the splenic cords. It's like stepping off a paved walkway straight into a swamp.
Wow.
To get back into the bloodstream, to get into the sinuses and go home, the red blood cells have to physically squeeze through tiny slits in the sinus walls.
It's a squeeze test. It's like those crazy game shows where you have to fit your body through a cutout in a moving wall.
It is perfectly ambidextrous to that. The slits are smaller than the diameter of the red blood cell, so the red blood cell has to be flexible. It has to deform, elongate, and get incredibly thin to pass through the slit.
So if you're a healthy, young, flexible red blood cell, you just slide right through like a gymnast.
Exactly. You pass the test, you enter the sinus, and you flow back to the heart. But if you are old, red blood cells live about 120 days.
Right.
As they age, their membranes get stiff. They lose that flexibility. Or what if you have a disease like spherocytosis, where the cell is naturally round and hard?
Then you get stuck.
You get stuck. You can't fit through the slit. You are permanently trapped in the cords.
And if you get stuck, who is waiting for you in the swamp?
The macrophages. The macrophages in the red pulp are the bouncers. They are constantly patrolling the cords. If a cell is trapped, the macrophage realizes it's compromised and eats it.
Just eats it.
Yes, it's phagocytosis. It's the body's ultimate quality control system.
That is brutal, but so efficient.
It,
You can't do the splits. You're dinner.
it ensures only the best, most efficient red blood cells are circulating to carry oxygen. Now, there is a shortcut. The other 10% of the blood takes a direct route through arteriovenous communications, completely bypassing this gauntlet. But the vast majority has to run the obstacle course.
And the flow rate is pretty high, right? I mean, how much blood is going through this thing?
About 300 milliliters per minute. Think about that. That's essentially a can of soda's worth of blood passing through this tiny organ every single minute.
That is a lot.
The entire blood volume of your body passes through the spleen every 20 minutes or so. It is constantly screening.
Incredible. Okay, so we've got the structure. We've got the obstacle course. Now let's talk about the 5 superpowers. The source material lists 5 distinct functions. Basically, why do we keep this organ?
The first, and perhaps most critical in our modern understanding, is the immune function.
We mentioned the white pulp earlier, but give me the stats on this. How much of our army is stationed here?
The spleen holds about 66% of the body's T cells and 10-15% of the B cells.
Whoa, 2/3 of your T cells. That is a massive chunk of your immune army stationed in one single place. It's like the Pentagon of the immune system.
It really is. And it's the major site for producing IgM, immunoglobulin M. This is the very first antibody the body produces when it encounters a new infection.
Okay.
But even more fascinating is the synthesis of opsonins, like tuftsin and properdin.
Opsonins. I always think of these as like condiments for bacteria.
That's actually a brilliant analogy. Let's break that down. Some bacteria, like pneumococcus, have a thick outer capsule. It's like a slippery suit of armor.
Right.
The body's normal immune cells, the phagocytes, can't grab onto them. They just slip right off.
So the bacteria is invisible or just too slippery to catch?
Both, effectively. But opsonins are specialized proteins produced by the spleen that stick to that capsule. They tag the bacteria, they coat it entirely.
So it puts a handle on the slippery suit.
Exactly. Or, to use your analogy, it puts ketchup on it. It makes the bacteria delicious and visible to the macrophages. Without the spleen producing these specific opsonins, tuftsin and properdin, the immune system has a very, very hard time seeing and eating these specific encapsulated bacteria.
So the spleen is the guy putting the laser target on the enemy. Eat that one right there. That completely explains why people without spleens are so incredibly vulnerable to those specific bugs.
Precisely. Now, superpower number 2 is the filter function. We touched on this with the red blood cells, but it also filters cellular debris, bacteria, and old platelets.
And it recycles. It's the ultimate green organ.
Yes, absolutely. When a red blood cell is destroyed, it's full of hemoglobin. You don't want to just lose that.
No.
The spleen breaks down the hemoglobin, strips out the valuable iron, and returns that iron to the plasma. It travels back to the bone marrow to be used to make brand new cells. Nothing is wasted.
Superpower number 3. This one is my absolute favorite. Pitting.
Pitting is remarkable. It's essentially microsurgery on a cellular level.
So imagine a red blood cell has a little flaw inside it. Maybe a nuclear remnant, like a piece of DNA that shouldn't be there, or a precipitated bit of hemoglobin.
Right. We call these Howell-Jolly bodies, which are the nuclear remnants, or Heinz bodies, the precipitated hemoglobin. In a normal organ, the body might just destroy the whole cell because it looks defective. Throw the whole thing out.
But the spleen,
The spleen is much more sophisticated. As the cell squeezes through that sinus wall we talked about, the spleen can physically pluck these inclusions out of the cell without popping the cell itself.
it's like removing a pit from a cherry without breaking the skin, or, taking a tiny splinter out of a finger.
And then it returns the newly repaired cell back to circulation. It's not just a garbage disposal, it's a repair shop. It actively extends the life of the red blood cell.
That is mind-blowing, for repairing individual cells on the fly as they pass through. Okay, number 4 is the reservoir function.
As we said, this is more prominent in animals, but even in humans, the spleen holds about 8% of the red cell mass.
A little backup tank.
Yes. And if the spleen becomes enlarged, which is splenomegaly, it can hold a much, much larger proportion of the blood volume, sometimes up to 40%.
Wow.
That actually becomes a huge problem because that blood isn't circulating, it's just sitting there trapped.
We call that sequestration, right?
Right.
And finally, number 5, cytopoiesis. That's a fancy medical word for making blood.
It is. In the fetus, around the 4th month of gestation, the spleen is a primary blood factory. It's actively making red blood cells and white blood cells.
But it stops after birth?
Usually, yes. By birth, the bone marrow has fully taken over. But here's the really cool part. The spleen never loses the ability to do it.
Oh, really?
If the bone marrow fails in an adult, say in a disease like myelofibrosis where the marrow turns to scar tissue, the spleen can actually remember its old job. It undergoes extramedullary hematopoiesis.
It comes out of retirement. Bone marrow's down. Don't worry, I got this.
Exactly. It starts making blood again to keep you alive. It's an incredibly adaptive, resilient organ.
Okay, so it's clearly a superhero. But even superheroes have glitches. Let's talk about congenital abnormalities. What happens when that folding and rotating in the embryo goes wrong?
Well, you can have a genesis where the spleen is missing entirely. That's very rare and usually linked to severe heart disease. Or you could have polysplenia, where you have multiple small spleens because the tissue just failed to fuse together into one nice organ.
But the one that really caught my eye in the sources, and the one that apparently terrifies surgeons, is the splenunculi, the accessory spleen.
Ah, yes, the hidden enemy.
The source material says these are present in 10 to 30% of the population. That means 1 in 3 people listening to this deep dive right now might have an extra mini spleen hiding inside them.
It's extremely common. They are usually small nodules of completely functional splenic tissue, just separated from the main mothership.
Where do they hide?
They can be almost anywhere in the abdomen. 50% are near the hilum of the main spleen. 30% are hiding behind the tail of the pancreas. But they can be in the mesocolon, the ligaments, or even way down in the pelvis near the ovaries or testes.
It's like a biological Easter egg hunt. But why does this matter? Who cares if I have a tiny spare battery?
It matters hugely for surgery. Let's say you have a patient with ITP, idiopathic thrombocytopenic purpura. This is a disease where the spleen is destroying the patient's platelets. The definitive treatment is to remove the spleen entirely.
Okay, spleen is gone, source of destruction is gone. The patient should be cured.
But if you missed a tiny accessory spleen hiding behind the pancreas, that little nodule is still there.
Oh, no.
And now that the main spleen is gone, that little nodule senses the demand, it undergoes hypertrophy, it physically grows.
It hulks out.
It hulks out. It gets big enough to take over the entire function of the missing spleen, including the pathological function of destroying the platelets.
So the disease just comes right back.
The disease comes back, the platelets drop again, and the surgeon realizes they missed a spot. It's a game of hide and seek with very high stakes. You have to go back in, find the accessory spleen, and remove it too.
That is wild. You think you're done, you go home, and the mini spleen says, surprise.
We also occasionally see cysts and hamartomas.
Hamartomas.
These are rare, benign tumors, just a mix of splenic tissue disorganized in a lump. And cysts can be true cysts, which are lined with epithelium, or pseudocysts, which usually come from trauma or pancreatitis, where fluid just gets trapped.
Okay, let's move into the danger zone. Vascular pathologies. This is where things get really scary and urgent.
We have to talk about splenic artery aneurysm.
The stats here are really interesting. About 0.04 to 1% of autopsies find them. And they are twice as common in women.
Yes, an aneurysm is a ballooning or weakening of the artery wall. And remember, the splenic artery is incredibly tortuous and has very high blood flow.
And they're often called the silent killer. Why
Ugh.
silent?
Because they're usually completely symptomless. You don't know you have a weak spot in that artery until it ruptures.
And there's a specific group at massive risk here, right?
Yeah.
This part of the reading gave me chills.
Pregnant women.
Yeah.
For reasons we don't fully understand, though it's likely related to hormonal changes weakening the vessel walls combined with increased blood volume, rupture of a splenic artery aneurysm very often happens in the third trimester of pregnancy or during labor.
Oh my gosh. Imagine that scenario. You're in labor, ready to have a baby, and suddenly a major artery bursts in your abdomen.
It is catastrophic. The mortality rate for the mother is terribly high because it mimics other labor complications like placental abruption, so that often gets missed initially.
Right.
And for the fetus, it's almost inevitable death because the mother's blood pressure crashes so incredibly fast.
That is terrifying. Just completely out of the blue.
That's exactly why if we find one of these aneurysms in a young person or a woman of childbearing age, even if it has absolutely no symptoms and is small, we treat it.
You don't wait.
We don't take the risk. We might use embolization, which is clogging it from the inside, or stenting to close it off long before it becomes a tragedy.
Then there's infarction. Is
Yeah.
that basically a heart attack for the spleen?
In a way, yes. It's when the blood supply is blocked. This happens quite often in sickle cell disease, or if the spleen is massively enlarged and simply outgrows its own blood supply, or if you have dirty emboli.
Dirty and emboli.
Infected clots. Say a patient has endocarditis, which is an infection on the heart valves. A tiny piece of that infected vegetation breaks off, travels down the bloodstream, and gets stuck right in the splenic artery.
Gross. And painful.
Extremely painful. The patient feels sharp pain in the left upper quadrant, and here's a very classic clinical sign. The pain often radiates directly to the left shoulder tip.
Why the shoulder? The spleen is in the belly.
It's called Kerr sign. The inflamed spleen irritates the diaphragm right above it. The diaphragm shares nerve roots C3, C4, C5 with the shoulder. So the brain gets confused and thinks the pain is actually up in the shoulder.
The body is wired so strangely. And finally, rupture. This is the big trauma scenario.
The spleen is the most frequently injured organ in blunt abdominal trauma. Think steering wheels, seat belts, handlebars on a bicycle. It's fragile. It's essentially like a tight bag of blood.
And the source material mentions something highly specific about malaria.
Yes. In tropical countries, repeated malaria infections cause the spleen to enlarge massive amounts. A malarial spleen is incredibly, incredibly fragile. The capsule gets stretched paper thin.
Oh.
The source notes that even a trivial injury, just bumping into a table or getting a friendly pat on the back, can cause it to burst.
So a little bump that wouldn't even bruise a normal person could be suddenly fatal.
Absolutely. And emergency surgery is very challenging because the tissue is so soft and friable. It's like trying to stitch wet tissue paper together. It just tears.
We've been talking a lot about enlarged spleens. Let's dive into that properly. Section 6, the enlarged spleen.
Splenomegaly.
First off, define hypersplenism. Because just having a big spleen isn't the whole story, is it? You can have a big spleen that works totally fine.
Correct. Splenomegaly is just about physical size. Hypersplenism is a syndrome of function.
Okay.
It's a combination of three things. 1, an enlarged spleen. 2, a reduction in blood cells, so anemia, leukopenia, or thrombocytopenia. And 3, the bone marrow working overtime to try and compensate for the loss.
So the spleen is working way too hard. It's eating the good guys.
Exactly. It's turned from a highly discerning bouncer into an indiscriminate shredder. It's trapping and destroying perfectly healthy cells just because it's hyperactive.
What causes the spleen to get this big in the first place? The source has a whole list of suspects. Let's run through them.
We can categorize them to make it easier to digest. First, infective causes. Bacterial infections like typhoid or TB can cause rare cold abscesses. But the really big ones are parasitic, malaria, obviously, and schistosomiasis.
Schistosomiasis is huge in parts of Africa, Asia, and South America. It's a worm, right?
Yes. The worms live in the blood vessels. Their eggs travel to the liver and spleen. The eggs get trapped, causing massive inflammation and severe fibrosis. The spleen reacts to the eggs and the toxins and grows absolutely huge.
Then we have the hematological causes.
The blood cancers.
Leukemias, lymphomas, and the anemias we mentioned earlier, like thalassemia and sickle cell. If the spleen is constantly chewing up defective cells, it undergoes work hypertrophy. It gets big, like a muscle that's being exercised way too much.
And metabolic causes.
Storage diseases. Gaucher's disease is a classic one. It's a lipid storage disorder where fatty substances just build up endlessly in the spleen cells. Or porphyria.
The source mentions porphyria causes port wine urine. That is a visual detail that really sticks with you.
It really does. It's a rare metabolic defect.
And finally, circulatory. This ties right back to the plumbing we discussed earlier. Portal hypertension. If you have cirrhosis of the liver, the blood just can't get through the hardened liver. It backs up. The spleen acts as a sponge, soaking up all that immense back pressure. It inflates. This is actually one of the most common causes of splenomegaly in the West.
I want to deep dive into a few specific diseases here because the source gives us some incredible detail on them. Let's start with ITP, idiopathic thrombocytopenic purpura. We touched on it briefly with the accessory spleen, but what is actually happening in the body?
This is a classic autoimmune condition. The body's immune system gets confused and starts making antibodies, specifically IgG, against its very own platelets.
And the platelets are the cells that help your blood clot.
Right. So these rogue antibodies stick to the platelets. They tag them. Now, as these tagged platelets circulate through the spleen, the macrophages in the white pulp see the tag.
And they say enemy.
Exactly. They destroy the platelets. So the patient rapidly runs out of platelets. They can't clot their blood.
What are the visible signs of that?
Petechiae, which are tiny red dots on the skin, which are actually mini bleeds. Bruising from absolutely nothing. Spontaneous nosebleeds. And in women, dangerously heavy periods or menorrhagia.
And the treatment.
We usually start with steroids to suppress the immune system, but if that fails, or if the patient keeps relapsing, we take the spleen out.
Does taking it out actually work?
In about 2/3 of patients, yes, it's a definitive cure. By removing the spleen, you are removing the primary site of destruction and a major site of the antibody production itself. You fix the problem right at the source.
Amazing. Next one on the list, hereditary spherocytosis. This sounds like a weird geometry problem.
It basically is. It's a genetic defect in the membrane proteins of the red blood cell, specifically structural proteins like spectrin or anchorin.
These proteins are like the scaffolding of the cell.
Exactly. They hold the cell in its correct shape. Normal red blood cells are biconcave discs, sort of like a donut without the hole fully punched out. They are flat and very flexible.
But in this disease,
The scaffolding is weak. The cell loses membrane surface area and literally becomes a sphere, a perfectly round ball.
and remember the squeeze test in the red pulp.
Exactly. A sphere is the most volume-efficient shape in nature, but it is not flexible at all. It cannot flatten out. So when it hits those tiny slits in the sinus wall, it cannot squeeze through. It's physically impossible.
So the spleen assumes they are broken.
The spleen assumes they are old or damaged. The macrophages eat them all up. So the patient gets very anemic from low red cells and jaundice from the massive breakdown of hemoglobin.
So the spleen is actually doing its job correctly. It's filtering out rigid cells like it's supposed to. But the cells are just genetically rigid from birth.
Correct. The spleen is hyper-functioning on cells that don't actually deserve to be destroyed yet.
So the solution is fire the bouncer, take the spleen out.
Remove the spleen. The spherical cells are still spherical. We didn't fix the genetic defect, but since they aren't being forced through the strict filter anymore, they can survive in circulation much, much longer. The anemia completely resolves.
That is such a clever workaround. But the source notes we usually wait until the kid is 6 years old.
Yes. Because of the severe infection risk, you want the child's immune system to mature a bit and get all their major vaccines before you take away their main bacterial shield.
Makes total sense.
Yeah.
Now, sickle cell disease. This is a heavy one.
This is tragic. The hemoglobin S crystallizes when oxygen levels are low in the blood, making the cells sickle-shaped. They become rigid, pointy, and very sticky.
And they get stuck.
They block the blood flow everywhere in the body, but especially in the slow, open circulation of the spleen. This leads to endless microinfarcts, basically tiny strokes, inside the spleen itself.
So the spleen is being starved of oxygen by the very cells it's trying to filter.
Exactly. Over time, these repeated infarcts cause massive scarring. The spleen shrinks, it fibroses, eventually it shrivels up completely.
It kills itself.
We call it autosplenectomy. By adulthood, many sickle cell patients effectively have zero spleen function left. Even if the organ is physically still there on a scan, it's just a useless lump of scar tissue. They are functionally asplenic and at very high risk for life-threatening infections.
Wow. Okay, one more on the list. Thalassemia.
This is a complex defect in hemoglobin chain synthesis. The red cells are highly defective and extremely fragile. The spleen destroys them very aggressively. Splenectomy helps here mainly to reduce the patient's constant need for blood transfusions.
Okay.
If the spleen is just eating all the donated transfused blood, taking it out helps that donor blood last much longer in the patient's system.
Okay, we've diagnosed all the problems. Now we need to fix it.
Yeah.
Section 7, the operation. Splenectomy, taking it out.
This is high-stakes surgery.
How do we actually do it? The sources mention the old school way and the new modern way.
The open technique is the classic approach. A large midline or subcostal incision. You open the belly wide. You have to meticulously deal with those ligaments we talked about earlier, the gastrosplenic and leonormal. You have to cut them very carefully.
And watch out for the pancreas.
Always watch the pancreas. You rotate the spleen medially to expose the back, clearly identify the delicate tail of the pancreas, protect it, ligate those massive splenic vessels, and carefully lift it out.
But the laparoscopic method sounds way cooler. The modern way.
It is the absolute standard now for elective cases, like ITP. The patient is placed on their right side, you use small ports and cameras. But the major mechanical challenge is, how do you get a solid, fragile organ out through a tiny 1-inch hole?
This is the part I love, the bag.
Yes, the bag. You dissect the spleen free, cutting all the attachments while it's still inside the belly. Then you slide a sterile, heavy-duty plastic bag through one of the ports. You maneuver the free-floating spleen directly into the bag while still inside the abdomen.
It's like building a ship in a bottle, but in reverse.
Then you pull just the neck of the bag out through the small incision. The spleen is totally trapped inside the bag, which is now hanging halfway out of the patient. Then you use surgical instruments, or sometimes even your fingers, to aggressively crush the spleen inside the bag and pull it out in tiny pieces.
You literally crush it in the bag. That is so visceral. More salation, right?
Yes, more salation. It sounds quite barbaric, but it brilliantly allows you to remove a 15-centimeter organ through a 2-centimeter hole. It's fantastic for the patient's recovery time. But you have to be incredibly careful not to rupture the bag.
Why? If you spill some spleen juice, does it really matter?
It matters huge amounts. If pieces of splenic tissue fall back into the abdomen, they can readily implant on the intestines or the peritoneum. They gain a blood supply and start growing. This is called splenosis.
You accidentally create a dozen accessory spleens.
Exactly. And if you were doing the surgery to cure ITP, you just failed the surgery completely. The disease will come right back because you just planted seeds of functioning spleen all over the belly.
That is wild. Medical gardening gone terribly wrong. But sometimes you try to actually save the organ, right? Conservation?
Absolutely, especially in trauma cases in young kids. If the spleen is just torn from a bike accident, we might try to glue it, stitch it, or even wrap it in a dissolvable mesh bag just to hold it together while it heals. We want to preserve that vital immune function if we possibly can.
Because living without a spleen is risky. Which brings us perfectly to Section 8. Living without a spleen. This is probably the most important part for the listener to grasp.
The post-op reality, it changes things.
Immediately after the surgery, what are the acute risks?
Bleeding, obviously, is number one. A slipped ligature on that massive splenic artery is a total nightmare. Also, gastric dilation. The stomach can get temporarily paralyzed because you're messing with the nerves nearby. And a pancreatic fistula.
Right, if you nicked the tail.
Exactly. If you nick the tail of the pancreas, digestive enzymes leak out and start digesting the patient's insides.
Terrifying. But the real long-term monster we have to talk about is OPSI.
OPSI, opportunistic post-splenectomy infection. Or it's sometimes called overwhelming post-splenectomy infection.
Overwhelming is a very scary word to hear in medicine. It's not mild. It's overwhelming.
It is used for a very specific reason. Without the spleen, the body loses its primary rapid defense. It loses that opsonizing ability against encapsulated bacteria. The big three culprits are Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza.
And if these bugs manage to get into the bloodstream?
In a normal person with a spleen, you get a fever, you feel crummy, you eventually go to the doctor. In an splenic patient, it can progress from a mild fever to full-blown septic shock, massive adrenal hemorrhage, and death in 12 to 24 hours.
12 to 24 hours. So you wake up with a scratchy throat and you could be dead by dinner.
It hits incredibly hard and fast, the bacteria just multiply in the blood completely unchecked because the spleen isn't there to filter them out or tag them. The mortality rate is 50 to 70% if it's not caught and treated immediately.
And the risk is highest in young kids and those with thalassemia, right?
Yes. But it's a lifelong risk for absolutely anyone without a spleen. Even 30, 40 years after your surgery, you're still at major risk.
So we need a survival guide. If I am listening to this and I don't have a spleen, what do I do to stay alive?
First line of defense, antibiotics. Children often take daily prophylactic penicillin until age 10, or sometimes lifelong. It's constant, low-level shield.
And vaccinations, of course.
Crucial. You need the pneumococcus and meningococcus vaccines renewed every 5 years. You need the hive vaccine every 10. And you absolutely must get a yearly flu shot because the flu virus can easily damage your lungs and open the door for those specific bacteria to get in.
There's a highly specific warning in the source literature about animal bites.
Yes.
This is bizarre but incredibly vital to know.
Yes. Capnos cytophaga canomorsus.
That is a mouthful of a bacteria.
It is. It's a bacteria found normally in the mouths of almost all healthy dogs and cats. It's totally harmless to them and usually completely harmless to humans. But if a dog bites someone without a spleen, this specific bacteria can cause overwhelming sepsis and massive tissue gangrene.
So if you don't have a spleen and a dog nips you, even just a playful nip that barely breaks his skin,
You go to the emergency room immediately. You need heavy antibiotics right away. Do not wait and see if it gets red. Do not just wash it and put a Band-Aid on it. It can absolutely be fatal.
bow. And what about travel?
Malaria is the big one. As we detailed, the spleen normally fights malaria. If you don't have a spleen, a malaria infection is much more likely to be severe or fatal. You need strict mosquito barriers, bed nets, and prophylactic anti-malarial meds. You simply cannot mess around with tropical travel.
And finally, the medical alert.
Always wear a medical alert bracelet. Carry a card in your wallet at all times. If you are ever unconscious in a car accident, the ER doctors need to know you are a splenic the second you roll through the doors so they can hit you with broad-spectrum antibiotics fast. It changes the entire management plan.
It's a completely life-changing condition. You can live a perfectly normal life, but you have to be vigilant forever.
Exactly. You are walking around without your main shield. You have to actively be your own shield.
So let's bring it all home. We've gone from the tiny embryo twisting in the primitive gut all the way to the high-tech surgery of crushing massive organs in plastic bags.
We certainly have. We've seen that the spleen is a highly sophisticated filter, a master of systemic recycling, and a 5-star general in the immune army.
It's definitely not just a purple blob. It's doing complex microsurgery on your red blood cells every single minute of your life. It's checking their ID and testing their flexibility at the door.
The pitting function really is the major takeaway for me. The fact that it can carefully heal a cell rather than just blindly destroying it shows how deeply elegant the body's design truly is. It heavily values conservation.
It's just amazing. And here is a final thought for you listeners to chew on as we wrap up. We talked about the accessories spleen earlier. The stats say 1 in 10, maybe even 3 in 10 of you walking around and listening right now have a second secret spleen hiding in your abdomen.
It's a very distinct possibility.
You might have a backup generator you didn't even know about, just hiding behind your pancreas, waiting for its moment to shine. It really makes you wonder what else is hiding in there.
Biology is full of surprises, always.
It sure is. Thank you for taking this deep dive with us today. Stay curious, check your vaccination cards, and appreciate that purple powerhouse under your ribs.
See you next time!